Presentation, please.
Of course. It's a pleasure to introduce the next speaker. Is Dr. Winfree, is professor of neurosurgery at Columbia. He's expert in both pain surgery and peripheral nerve surgery. So we're really much looking forward to this talk on medical management of pain after nerve and nerve root injury. The floor is yours.
All right, thank you. And thank you everyone for attending, and thank you for the organizers and the moderators and my co-panelists. I'm a consultant for a company. We're doing a clinical trial. I'm the lead proceduralist. I've not gotten paid at all, so really there's no disclosures relevant for here. Today we're talking about neuropathic pain. Anyone who's had a dental drill knows exactly what that pain is like. It's often numbing, burning, tingling. Patients know exactly what this type of pain is, and they're very reliable at clarifying whether it's neuropathic pain versus one of the other types of pain. And one of the things about neuropathic pain, it can be more of a challenge to treat than, say, nociceptive pain, right? And so rather than just Tylenol or acetaminophen or low-dose opioids, it can be tougher to treat. And so for tackling severe neuropathic pain, we think about combination therapy, what's known as multimodal therapy, using some combination of medications that you may not normally think of as analgesics, such as the anticonvulsants, antidepressants, baclofen, and there are more, of course, and we'll go through some of these. This is not an exhaustive list, but these are the medications that as neurosurgeons treating neuropathic pain, you should have some familiarity with. And what this talk is going to do is introduce some of these drugs, how they work. And what's less important is me talking. What's more important is the list of references I'm providing you. And I would encourage anyone that wants to learn more about this to look at some of these references, because they're actually pretty up to date and they're pretty helpful. So when I first started treating neuropathic pain, I always wondered why there wasn't more of an algorithmic approach to this. And it turns out now that there is. It's a recently published paper going through some of the methodology in treating neuropathic pain, especially which is refractory to initial treatments. And it goes through sort of this treatment ladder from top to bottom. And I know this is a busy figure. So just looking at the different stages, monotherapy with some of these neuropathic pain agents is kind of the first step, followed by combination therapy, which we'll talk about, some of these synthetic low dose opioids. And then you get to that point, you got to send them to a specialist. And one of the take-home messages here is that as neurosurgeons, you don't have to be experts in this. You don't have to do all this yourself. Call one of your pain colleagues, phone a friend, get some help. You should not probably be managing these patients all by yourself unless really you have no other option. And then interventional therapies are further down the line. And then as we go further down, neuromodulation, which we'll hear about later, formal opioid therapy with escalating doses, and even targeted drug delivery at the end. So that's kind of the algorithmic approach. So let's talk about some of the drugs. The anticonvulsants are probably the first line agents you'll think of for treating patients with neuropathic pain. These are generally calcium channel blockers, also thought of as membrane stabilizers. They tend to prevent irritable nerve cells from firing. It reduces neuronal depolarization overall and reduces pain transmission. And these tend to be effective both for neuropathic and nociceptive pain. They're generally safe drugs with very few drug-drug interactions, but they can have notable side effects. Patients can be foggy, some can gain weight, there can be short-term memory issues. It often requires ramp up. Some of these medications like gabapentin can take a month or more to get to the maximum doses to limit side effects. And once these patients are on the medications for a while, you got to taper them gradually, otherwise they can get withdrawal, including seizures and rebound pain and other things. These pain medications can be tricky. They can be potentially teratogenic. So if you have people who are of childbearing age, you got to be careful. And in patients who are young, like adolescents and young adults, it can cause suicidality. So again, you got to be careful with that. The antidepressants, also first line, some consider them second line agents. Generally speaking, they increase the availability of epinephrine, norepinephrine, and serotonin, the adrenergic neurotransmitters. And the analgesic effects are independent of their antidepressive effects, because that's what patients are going to tell you first. Why you're starting me on an antidepressant when I'm not depressed? The reason is these medications increase the activity of these descending adrenergic circuits, which ultimately synapse on pathways that produce these opioid releasing pathways in the substantia gelinosa. So the bottom line is when you have somebody who has neuropathic pain and you give them an antidepressant, you increase the levels of opioid activity in the spinal cord and reduce pain levels, okay? So that's how you explain it to patients. Now, the antidepressants can have some drug-drug interactions that you really don't see with the anticonvulsants. The antidepressants can cause first-degree heart block. They can interact with thyroid replacement therapy, so you have to be careful with that. And again, like the anticonvulsants, they have ramp up and they have withdrawal issues, and they also can be teratogenic. So again, be careful with these medications if you're going to go down this route. Steroids, another good medication for anti-neuropathic pain effects. Steroids have direct anti-inflammatory effects and direct analgesic effects that are independent of each other. Generally, as neurosurgeons, we're comfortable using short courses of steroids, usually oral steroids. Think of a patient with an acute radiculopathy, like a Medrol dose pack or, a pulse dose steroid, pretty standard for neurosurgeons. But longer courses of steroids can be problematic, and they can have endocrine and infectious effects. High dose steroids can cause pneumonias and other infections. And anybody who's diabetic, their diabetes control can be really put out of whack with oral steroids. But again, this is good for nerve and nerve root type pain. Steroids can be injected locally. Intralaminar epidural steroid injections for leg pain, even back pain. Selective nerve root blocks to target radicular pain. Caudal injections to treat other sort of, neuropathic pain in the spine. And focal peripheral nerve injections, usually ultrasound guided, to treat peripheral nerve pain syndrome. It's very common. Personally, I use topical steroids, basically it's a variant of methylprednisolone. In the US, it's called Depomedrol. It's a 40 milligram dose. This is the standard dose you inject along nerves. I apply it topically whenever I operate on a sensory nerve, like occipital nerve decompressions, lateral femoral cutaneous nerve decompressions. These patients tend to get flare-ups of pain post-operatively. So at the end of the surgery, I apply a local anesthetic to the nerve, as well as 40 milligrams of Depomedrol to reduce the inflammatory response after surgery. And these patients are much happier afterwards. Baclofen is another medication you'll come across. This is a GABA receptor agonist. Historically, neurosurgeons use this to treat spasticity, right? Intrathecal baclofen to treat spasticity. But it's also a second and third line agent for treating neuropathic facial pain specifically and neuropathic pain in general. So again, it can be a powerful medication that a lot of people aren't really thinking about using, but keep this in your repertoire of pain management strategies. It's generally safe, and you just got to be careful with baclofen withdrawal once patients have been on it for a long time. The opioids, we all know about opioids. The opiates are drugs actually derived from opium, like morphine. The opioids are just any drug, including the synthetic drugs, any drug that interacts with the opioid receptor. And these include the synthetic drugs, the opioids, the enkephalins, which are the endogenous drugs, and any of the receptor blockers. So these drugs basically drive inhibitory G protein coupled receptors, and you're probably familiar with these, that generally work in the substantia nigra, substantia gelatosa of the spinal cord. And what this area does, it's an important integration center for pain where afferent sensory information comes in, and you have these descending inhibitory opioid circuits originally driven by the adrenergic circuits, and everything meets here in the substantia gelatosa, and whatever results, both the pro-pain and sort of anti-pain circuitry sort of sums, and whatever results get sent up to the brain as pain signals. And so opioids work not only here, they work all over the body, including the peripheral nervous system, and they're potent analgesics. And even for neuropathic pain, you don't normally think of them as being good for neuropathic pain, but they can be, especially patients who are in neuropathic pain crises, like trigeminal neuralgia. They're in the hospital, they can't eat. Yes, that can respond to opioids. But you got to be careful because opioids can have bad side effects, and there's a big time abuse potential for them. We usually think of opioids as a treatment ladder, with the bottom rungs being sort of the low potency opioids, and you kind of escalate up as needed to treat more and more, higher levels of pain. And this was worked out by the World Health Organization in the 1980s. So be careful with opioids, but understand that they can help neuropathic pain when it's sufficiently severe. Ketamine is an interesting drug. I'm not sure how accessible this drug is worldwide. It's a sedative hypnotic agent. Some people think of it as a horse tranquilizer. It's used in veterinary medicine. It's an NMDA receptor agonist. And so what that means, an antagonist. So what that means is it blocks the excitatory pathways within the nervous system, and it has a lot of effects. One of the most important effects is it can relieve pain. And what's interesting is it does not affect respiratory drive. So you can actually give a lot of this and not stop a patient's breathing. And it's really nice. And so in the past couple of decades, this medication was sort of, people became interested in it to treat complex regional pain syndrome. And even more recently, people have realized that it's actually good for neuropathic pain in general. And so you may see patients who are either on this or get intravenous infusions or even take it orally. What we found in our practice is we use it as part of our anesthetic regimen whenever we operate on a patient who has complex regional pain syndrome specifically, but also bad neuropathic pain generally, because it can really be helpful for patients. It keeps the patients quiet. If you're using not a general anesthesia, but using like a monitored anesthesia care or a sedation case, it can really keep patients under control while not affecting their breathing. And like these opioid tolerant patients who are really difficult to treat in the operating room, it can be a real helpful procedure or a drug as part of the anesthetic procedure and regimen. And our anesthesiologists have a lot of experience doing that. And I would encourage you to work with yours to accomplish the same. Historically, there's concern that it increases ICP, but more recent studies show it's probably not the case. Some patients do not tolerate ketamine. They get hallucinogenic. They don't like it. Some can develop conversion disorder, which can produce these, complex neurological deficits postoperatively, and that can be problematic. But generally, it's a safe and straightforward medication. Medical marijuana, another interesting drug. Not sure where it stands worldwide in terms of acceptance, but it's becoming more and more frequently used in the United States. These medications target the endocannabinoid system. Anandamide is the natural ligand in the body. Obviously, we know about THC, the psychogenic component of medical marijuana. It's a potent analgesic. It's also an antiemetic and an anticonvulsant, so a very useful drug. CBD, non-psychogenic, but it's also an analgesic, not as effective. Again, like ketamine, no respiratory effects. No one's ever died of a marijuana overdose. It doesn't stop breathing. And there's both natural and synthetic formulations. It can be smoked. It can be vaped. It can be put into edible food, like there's gummy bears that have the medication in it. Coffee can be infused with it. It's really a versatile drug. It can be incredibly useful for people who have chronic neuropathic pain that nothing else helps with. It's becoming increasingly legalized in the United States and maybe for the rest of the world. There's guidelines on how to use it. There's an emerging literature and evidence base for it. It can be really useful. A lot of patients have localized neuropathic pain, so small areas of the body that are painful. Think knee pain after a knee surgery or groin pain after a hernia surgery. A lot of times you don't have to hit patients with all these systemic medications. You can utilize locally applied topical medications, usually that are compounded at a pharmacy, custom made, where they cobble together several medications all into one cream that the patient sort of applies. Can be very useful. And again, there's a whole emerging set of guidelines and literature on this if you want to explore it further. Botox, another medication some of you may not be aware of, used for pain. Botox actually binds presynaptic proteins and inhibits vesicle release. So it limits the transmission of pain impulses. It's great for headaches and a lot of localized neuropathic pain syndromes. And it's generally injected directly along the painful areas. So these are the majority of kind of the more useful neuropathic pain medications you'll come across. As neurosurgeons, again, I would encourage you to have some working knowledge of these drugs. Whenever possible, if you have a patient with bad neuropathic pain, consider multimodal pain management therapy, where you basically start with monotherapy, you escalate up until there's side effects, then you back down, okay? So at that point, if they don't have sufficient therapeutic response or pain relief, add a second agent that works through a different mechanism. So maybe add an antidepressant to an anticonvulsant. Again, ramp up to side effects, then back down. And if that's not enough pain relief, add a third agent, ramp up to side effects, then back down. And you can use 2, 3, 5 even different medications all working together at sub-side effect doses, giving you these additive pain relieving effects. The anesthesiologists have worked this out a decade and a half ago. So this is kind of standard practice for people who are comfortable doing this. It's fairly algorithmic. As neurosurgeons, you don't have to do this all by yourself. Get help, call a pain colleague, call a friend, but your patients should not have to suffer. There are ways to treat them effectively. And basically, from a medical standpoint, this is how to do it. So I hope everybody got something out of this. I'm happy to take questions. And again, thank you to the organizers and my co-panelists. I'd be happy to take any questions.
Thank you very much. That was excellent, actually.
And we're right on time.
Always.
Perfect timing. So is anyone has got any question? Otherwise, I can start. Sorry, I couldn't read very well your algorithm, but I could just gather that basically neuromodulation sits before opioids, which is nice.
It is before
I want to know how
high-dose
you
escalation
manage your
opioids.
practice. Yeah.
Yeah. So there's been a move away from treating chronic pain with high-dose opioids. If you saw in the algorithm, tramadol's pretty early on. So you have somebody with short courses of neuropathic pain. You can use opioids initially a little bit, the weak opioids, but there's been a movement of a way of escalating up through that treatment ladder to high-dose opioids early on. You reserve that for almost to the end, because opioids can be really problematic, not just from a substance use disorder standpoint, but just think elderly patients with, bad back and leg pain. If you get them on high-dose opioids, the fall risk, right? Constipation, the substance use. I mean, there's a lot of issues in that. The thinking is that you should really do that after neuromodulation if you have access to neuromodulation, right? I mean, not everybody has dorsal root ganglion stimulators and pumps and everything else, but if you do, those tend to be better, lower risk options than high dose opioids. And that's why it's positioned that way on the algorithm.
Dr. Gogokulu has a question.
In your day routine practice, the short course, what is your short at most for opioid usage? Because New England Journal of Medicine exclamates, we need to use not more than 10 days in these publications in that journal. So I'm very, very, as a member of Massachusetts Medical Society, I really want to know what is short at most.
So it has to be tailored to the patient. Generally speaking, in my practice, I never write prescriptions ever for pain, except for the few days to a couple of weeks post-operatively. I have pain colleagues that take care of that, but post-op, I'll give patients half a dozen, Percocet or oxycodone. And if they need something more, we can extend that to a week or two, but I generally don't do anything beyond a few days. I don't consider 10 days a hard and fast rule. You have to tailor it to the patient. But generally speaking, when patients need weeks and weeks of opioids, like it may be necessary, but you should not, as a neurosurgeon, be getting into that. You should have a pain specialist deal with it at that point, is what I would say.
That was cool. That was
Any other questions?
Yes, Christopher, thank you for a great presentation. I also prescribe little pain medication because it's done by either the pain team or the general practitioner. But I personally like directly after the surgery to leave something locally. What's your experience with that?
Oh, absolutely. We do local anesthetic directly on the nerve, as well as the topical steroid that I explained. And that's been transformative in our practice, operating on sensory nerves. I find that motor nerves don't need it so much. There's something about the motor system, and this is being worked out in neuromodulation, where when you activate the motor pathways, that in and of itself has important analgesic effects. So for some reason, when you operate on a mixed motor nerve, ulnar nerve, median nerve, you tend not to see that amplification of pain post-operatively. But when you operate on a pure sensory nerve, because you don't have that influence, that analgesic effect of the motor pathways, those patients tend to flare up and get horrible pain syndromes, which is why we always topical local anesthetic, topical steroids whenever we operate on a pure sensory nerve. That's our experience, and it's really transformed our practice and our patients' post-operative experience.
Great, thank you.
One last question before moving to the next speaker. Anyone else has a question? Otherwise, I will ask. It's both for Dr. Winfree, Dr. De Ruyter. It's the use of local anesthetic for diagnostic purposes. Do you use it? So do you block the nerve before offering a procedure, either decompression, neurectomy, neuromodulation? Is it something that you use in your practice?
Yes, for neuroma treatment, definitely. So if you look at the studies, basically they give a local anesthetic, and the reduction in pain has to be at least 50% for the blockage to be positive. For the other cases, I find it very difficult to or kind of make your indication for surgery based on the local blockage, yes or no, because the patient just wants to have an operation. So it's not that you're going to treat them with the blockage, it's just to know whether they're going to improve, yes or no. But for neuroma treatment, I think it's very helpful also because you want to know whether the symptoms have become chronic or not. Because if the patient presents to you like years after the injury, and there's a neuroma and the local block is not going to give any relief, I don't think you're not going to operate the patient, but you can explain to the patient that the chance that the surgery is going to help is less than when the interval would have been shorter and there would have been a positive block.
I agree. I would further say that when you're interested in neuromodulation, the more important thing is the geography of the pain. Where is the pain? That helps you direct where your neuromodulation therapy is going to be targeting. It doesn't matter if the pain responds to a block, because neuromodulation can even work when there's centralized pain that presumably will not respond to a block, but neuromodulation can still work. So in the neuromodulation space, we don't rely on blocks really ever, because we know where the pain is and we know what neuromodulation device we need to use to get treatment there, and we don't worry about the blocks. But for surgical treatment of neuromas, especially if you're trying to figure out which branch is affected, again, I refer back to groin pain, knee pain, where it could be one of several different nerves. I think the blocks are crucial.
Thank you. I'll